Hi guys, I want a chance to talk to you about some of the big classes of dysrhythmias. And the first class we're going to talk about is atrial dysrhythmias, and these are ectopies. These are ectopic dysrhythmias. So atrial ectopies or atrial ectopic dysrhythmias are going to start up here in the atria, and we tend to think of atrial dysrhythmias as being fast and skinny. So rhythms that originate from the atria tend to have fast heart rates, and skinny, what we mean by that is the QRS is going to probably be within the normal range, less than 0.12, because whatever craziness happens up here, it is still all eventually going to funnel to the AV node and follow the normal bundle branch system. So from here down, activity is still going to have like a normal QRS of less than 0.12. So I'm going to see if we can get us quickly through these major atrial dysrhythmias. So remember, when we're talking about ectopy, we're talking about a cell that is not even on the conduction system. It's just supposed to be a contracting cell, but it's just over here somewhere. So we're talking about atrial ectopy. So let's just pick a cell. Could be this one. Could be over here, even in the left atria. Could be this one. So it's just a cell that's supposed to just contract, but for some reason it's become irritable and it's starting to get fizzy and it just wants to fire off some electricity out of turn. That's an abnormal response. And we talked about the major reasons why a cell might become ectopic, and then it would become an ectopic focus. If you have multiple, the plural is foci. So what would cause this cell to become ectopic? Well, it could be low on oxygen, electrolytes out of whack, could be stretch. And the cells in the atria are particularly susceptible to being physically stretched because the atria is very thin. It doesn't have a lot of muscle mass. And when you start getting into some fluid overload, the atria is one of the first areas to just get physically stretched out. So CHF can cause some atrial dysrhythmias right away. So let's say that you have this cell. So we'll just look at this one right now. This one cell, and it's the first one. It had the lowest threshold for feeling ectopy, for feeling irritated. And there might be a lot of cells that are feeling stretched and irritated, but whichever one had the lowest threshold, maybe the fastest intrinsic rate was built into its DNA, or it felt the most irritated, and it was just the first one to fire off. That's the one that's going to have the opportunity to jump in and make a beat. So as the sinus node is firing and it goes to the AV and it makes a sinus beat, and the sinus fires and it goes to the AV and it makes a sinus beat. So as that happens over and over, and this cell is receiving electricity, getting depolarized, passing it on, and it's contracting, but one time it jumps in early and makes an ectopic beat. So it has to get in there fast in order to get that extra beat in. And around it, sinus rhythm keeps on going. So sometimes a cell like this doesn't take over the whole heart rhythm. It's just every now and then throwing in an extra beat or a couple of extra beats. And that's when we see an uneven rhythm on the heart monitor. So they're going along mostly in sinus rhythm, but every now and then they just have one or they just have a couplet of these extra beats. A premature complex of some sort. And right now we're talking about premature atrial complexes coming from the atria. So what would they look like? Well, you got people going along in sinus rhythm. So they're going to have a P, a nice skinny QRS, and a T wave. And then they got another nice P and a nice skinny QRS and a T wave. And then before they can have their next beat, so it's got to be pretty close to this T wave, so the next one was going to come this far away again, but before it could happen, because it's got to be fast if it's going to jump in, you get maybe a different kind of P, because when electricity comes from a different direction, it changes the shape of the wave. When electricity comes from a different direction, it changes the shape of the wave. So maybe this P, these were upright, so maybe this P is below the line. Maybe it's upside down. Or maybe it's above and below the line. But it is still eventually going to go to the AV node and travel the same bundle branch system. So the QRS will look exactly the same. And then sinus, there might be a little space after it, and then sinus rhythm returns. So usually what you notice when people have PACs is you'll see sinus rhythm going along, and then you'll see two that look scrunched together. So let me see if I can draw it a little bit better for you. So you'll have a sinus beat. No, we don't have any curly cues in sinus rhythm. You'll have a sinus beat, something scrunched up right next to it, but matching QRSs. A little space after it. Sinus beat, T wave, something scrunched up right next to it. And it doesn't have to go in a pattern. It can go in a pattern, but it doesn't have to go in a pattern. And so then as I start looking at this patient's heart rhythm, what I start to notice is there's some like pairs occurring with little spaces after it. So when I see little couples occurring, what I know is that the second beat in that couple is scrunched up next to it. So the second beat in the couple is the early beat, is the premature complex. The second beat in the couple is the premature complex. And when you have a premature complex, it's either a PAC or it's going to be a PJC, a premature junctional complex. We'll look at that next. Or it could be a PVC. So there's three areas of the heart that an early beat could come from. It could come from the atria, the junction, or the ventricles. So I'm going to look at the premature beat, at the shape of it, at the look of it, and that's what's going to tell me where in the heart this premature beat came from. If it pretty much looks like a sinus beat, but it's early, then that came from the atria. So that's going to be a PAC. Okay, so we're going to look at some strips of those when we have class. And I'm going to pause because my phone is making noise. Okay, I'm back. So sinus rhythm with PACs is a very common rhythm, and it's very benign. PACs don't usually cause any problem. We don't really have to do any treatment. A lot of people with lung problems like COPD, this is their normal underlying rhythm, is sinus rhythm, sinus tach, because they tend to be a little hypoxic all the time with a lot of PACs. Let's say, now we're going to go to, let's do a WAP next, a WAP. So this is a uncommon rhythm, but it's kind of fun. So let's look at it just for a second. You don't see it that often. Let's say you had a few different spots, at least three. And one of them can be your sinus node, but let's do three different ones. So let's say you had this cell, that one we just talked about, that was feeling very ectopic. You have one over here, kind of pretty far away from the sinus node. And then maybe you got one right here. And all three of these cells are feeling ectopic and they all want to fire. But none of them is really dominant over the other one. None of them is a lot faster. And so none of them is jumping in way early and depolarizing to make a beat before the other ones. They're all about the same intrinsic speed. Then what can happen is sometimes this one will make a beat or two, and then that one will make a beat, and then this one, and then maybe that one will make a beat, and then that one will make a beat, and then that will make two, and then maybe your sinus node will make one, and this one. We call this a wandering atrial pacemaker, where somebody has multiple sites in their atria, and they're all kind of taking turns producing the heartbeat for the patient, because all of them have a similar rate, and the fastest pacemaking site is the dominant site that runs the heart rhythm. So if none of the pacemaking cells are really faster, none of them are really dominant. And electricity that comes from different locations all produce slightly different looking waves. So if they're coming from slightly different locations, then all the P waves are going to look a little bit different. What about the QRSs? Well, all the electricity comes to the AV node and goes down the same bundle branch system. So the QRSs all look exactly the same. It's only the P waves that are coming from different locations. So only the P waves look different. Now this is a really funky rhythm, and you only see it very rarely, but we might as well throw it in, and we'll look at a couple strips in class. So if this cell fired first, and it's really far away, let's say that it makes upside down P, like this, and you might have kind of a long PR. You might have a prolonged PR, but then it's going to go down the normal bundle branch system, so you get a nice skinny QRS like this, and a regular T wave. Okay. And then this one goes next, and it's pretty close to the sinus node, so it makes a pretty normal looking P. And you get the same exact QRS because it follows the same bundle branch system. And then it makes another one, so you get the same exact beat next time. I'll try to make it look the same. But then this one goes, and it's in a different location, and that one makes a biphasic P, above and below the line, and it has a slightly different PR interval. But the QRS will be the same because it goes down the same bundle branch pathway. So a wandering atrial pacemaker, the way that you're going to recognize it, the key criteria for a WAP is when you first look at it, it looks just like sinus rhythm. So your first impression of this strip will be, it looks like sinus rhythm. Then step one, is it regular? Well, when you start measuring the regularity, you're going to find that it's just ever so slightly irregular. And the reason is going to be because these PR intervals are going to be not all quite exactly the same. But you won't know that yet because you haven't measured them. So your eyeballs might not even notice it yet. You might be like, yeah, pretty regular. Then you do the rate. The rate's probably going to be pretty sinus, or maybe they're slightly Brady, but they're probably in a sinus rate even, because it's all coming from the atria. But they could be a little high, could be a little low, you know, nothing dramatic. Okay, then you're going to say, is there one P for every QRS? And this is where you're going to see that they're in some kind of weird dysrhythmia. Because as you look at one P for every QRS and you measure the PR intervals, you're like, oh, they have inverted Ps in lead 2. That's a little bit weird. And their PR, you're like, oh, that PR is a little bit prolonged. So they don't have a normal measurement. And you're like, oh, but that P goes up. And this one is a normal measurement. And the next one is the same as the second P. So they have two different Ps with two different measurements. Oh, and look, now they have a third shaped P with a third measurement. If you have at least 3 different Ps, that's a wandering atrial pacemaker. So it means they have at least 3 different cells that are firing. Now, if any of these cells decide to speed up, they will take over, and then you'll just have one type of beat, and it'll probably be much faster than this. But as long as they're all about the same speed, it'll just keep switching back and forth, and that's wandering atrial pacemaker. Wandering atrial pacemaker is usually benign as long as the pulse rate is okay, then the patient feels okay. As long as all these PRIs are within reason, they're probably getting atrial kick, so they probably have good cardiac output and they're unlikely to have any symptoms. So if they have no symptoms, then we do not need to do any treatment. We can just watch them, but we know that they are having atrial ectopy. So we have to say to ourselves, why are they having atrial ectopy? Do we need to give them Lasix? Are they in fluid overload? Have we checked their electrolytes today? What is their oxygenation status? So we would look at these reasons for ectopy and see if we need to treat any of these things. And of course, if the physician does not know that they're in wandering atrial pacemaker, then this is something that we would report. So we do definitely report it, even though we're not going to rush in with anti-dysrhythmic drugs. We're not going to put a pacemaker on it. We don't have to do anything to them, but we do have to notice it and try to treat the underlying cause. All right, moving on. Let's talk about SVT. Now we're getting into the big stuff. Now we're getting into the goods over here. All right, let's go back to that original ectopic focus right here, this original bad guy. So let's say this one cell is seriously agitated and he is getting very fast, like really fast, definitely over 150 for sure, maybe over 160, maybe even getting up over 180 beats per minute, so way over what sinus tach would normally be, and that's one way we're going to differentiate supraventricular tachycardia from regular old sinus tachycardia. If it gets really fast and it's not just inserting an occasional beat until it can beat every single sinus beat, it can get ahead of every single sinus beat until you can't get any more sinus beats in, and your whole heart rhythm is now nothing but these ectopic beats. So this cell now completely takes over from your sinus node, and your heart rhythm is nothing but a whole string of beats coming from this ectopic focus. So like na 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 na. Your sinus node never gets a chance to fire, because every time it wants to fire, it's receiving electricity from this ectopic focus, and the sinus node now is forced to depolarize and then repolarize, and it never has a chance to fire because it's now slower than this point. So the fastest focus, the fastest cell becomes dominant and takes over the heart rhythm. So SVT has a very distinctive look to it. It looks like a skinny QRS, and by skinny, we always mean less than 0.12. And one lump in the middle. And I don't know if this lump is a P wave, a T wave, two things on top of each other. I just know it's one lump, a skinny QRS, one lump, a skinny QRS. Why is it skinny? Because everything's still happening up here, and all the electricity is going to come to the AV node and go down the bundle branches. So you still get a normal QRS. All right, so let's look at what it looks like. You're going to get a normal skinny QRS, less than 0.12, but then you just get one lump. Skinny QRS, one lump. Skinny QRS, one lump. Skinny QRS, one lump. This is the most common look for SVT. Something like this. Now, of course, they all look different, but that's what they have in common is you're like, what is that one lump in the middle? Is that the T wave? Is there a P wave? Where is it? I don't know. Skinny QRS, one lump, skinny QRS, one lump, skinny QRS, one lump. So the morphology is one way you can tell SVT. Another way you can tell SVT is the rate. It's much faster than sinus tachycardia. Sinus tachycardia doesn't really want to go a lot faster than about 150, 160. Pediatrics are different, obviously, but in an adult, SVT can approach 200. So it can go greater than 180, and it can even start going up towards 200. And SVT is a subject where, like, I've gone to a whole weekend workshop before that's just SVT. There's a million different kinds of SVT. People can do a thing where they have accessory pathways of conducting cells that bypass their AV node so that they don't have any electricity weight right here. And they can get electricity that then gets back on the conduction system and goes retrograde up here, and they can get electricity caught in a loop. And when people get caught in a loop, they can get heart rates that go even above 250. So it can be crazy. They have, like, there's a type of problem called Wolff-Parkinson-White syndrome, WPW, where they come in with these super high heart rates above 250 in the ER. That's a type of SVT that's very extreme, and we can't give them beta blockers. They actually get worse if you give them beta blockers. So SVT is a topic that you could go into with a lot more depth. So if you go into an area of cardiology, if you work in cath lab, ER, if you go to electrophysiology lab, any of these places, you can definitely learn a lot more about SVT. But as a starting place for 90% of the hospital and just like first response of where you want to work, here are the things you need to know about SVT. You hear the alarm go ding, 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 and you look up and you see something that's skinny QRS, one lump, skinny QRS, one lump, skinny QRS, one lump. The rate is higher than sinus tach would usually be, like probably greater than 180, maybe even going up towards 200. The third criteria is it's paroxysmal, meaning it begins suddenly and ends suddenly. So they're going along in sinus rhythm, and one PAC is what trips it. That first PAC gets in there, it gets in, and then it's like na 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 na, and it can end very suddenly, sometimes just with a vagal maneuver as simple as a cough. So they're like na 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 na, and they cough, and it goes back to sinus rhythm. So it's paroxysmal, begins and ends suddenly. High heart rate and morphology. That's how you're going to know it's SVT. All right, treatment for SVT. We got a couple different treatments. So I always put TX for treatment. Well, it depends on how the patient is. But we got a couple different steps. So step 1. Vagal maneuvers. A lot of people can vagal themselves right out of SVT. So first of all, you should know that SVT a lot of times is self-limiting. So by the time you even get down to the room to check on them, it's already stopped. In which case, we'll just document the strip and alert the MD if we're not in the ER or something and they haven't seen it already. So people will feel SVT because they feel like the heart palpitations when they have SVT. Probably a lot of people in the class have had it before. SVT is not totally uncommon. It's more common in women. Even kids come in a lot of times with SVT. If you ever take a diet pill, you probably had some SVT. So the patient will probably have some symptoms. You ask them how they're feeling. You get some vital signs on them, stuff like that. If they are fairly stable, so they're not having chest pain, they have not lost consciousness, they got some blood pressure, right? So these things mean they're stable. They're not confused, right? So they haven't moved from their baseline LOC, so they're stable. Step 1, vagal maneuvers. Have them cough, but it has to be a big cough where you increase the interthoracic pressure. It can't be like a wimpy cough. It has to be like a really good cough. Has to really increase the internal pressure. So a lot of people can cough out of SVT. And little kids that are in the ER, sometimes we have them blow in a straw, and then we pinch the end of the straw. So like school-age kids, so we tell them to blow really hard, and right when they blow, we pinch it. So they go, oh, like that, and it increases the pressure. It's kind of a mean trick. Or you can have them bear down, but that's not my favorite one. So if they're stable, step 1, vagal maneuvers. Step 2, we go to drugs as long as a person is stable. And we have a medication specifically for breaking SVT. So the only thing this drug is for is breaking SVT. That's it. It's a special drug. It's the only drug in its own class. It's an SVT breaker drug, and that drug is adenosine. Adenosine. So first we give 6 milligrams rapid IV push. So it has a super short half-life. So you have to have your flush all ready. There's all different ways to give it, but you give it like through a running IV, or you can have like where you have your med lower and your flush right above it, and you go whoosh, whoosh. So you just have to make sure you don't, like, if you give it and then you take that off and then you go over here and you pick up your flush and then you come over and you put your flush on and you get ready to give that. By the time you do that, half of it is already gone in the tubing before it's in their arm because it's gone quickly. So you got to be like, give it really quick because that's short half-life. When you give the adenosine, there's a famous side effect, which is it puts them into asystole. Actually, it's not a side effect. It's the therapeutic effect of the drug. So adenosine is like cardioverting somebody with a medication. When we cardiovert or defibrillate people, we wipe them out to asystole and hope that the better rhythm is underneath, right? So adenosine is a drug that wipes them out to asystole to let the sinus rhythm that is hopefully underneath come out. So they'll go into asystole, but it has a very short half-life, so they'll pop back up in a second. They're either going to come back into SVT, but it works pretty good, so a lot of times they'll come back in sinus rhythm. It'll give their sinus node a chance to reassert its dominance. If 6 milligrams doesn't work, we follow up with a dose of 12 milligrams, and if that doesn't work, we can do another dose of 12. That's the recommended schedule. Some docs will tell you to do more, but 6, 12, 12 that's the FDA approved dosage schedule. Okay, 2-step treatment. If the patient is stable, vagal maneuver, adenosine, 6, 12, 12. What happens if you go in the room for SVT and the patient is not stable? So you run in there and they're still in SVT by the time you get in the room, and you go in and the patient, it looks unconscious. What is the first thing you should do if the patient looks unconscious? You check on them. Hey, are you okay? And let's say that they groan. Okay, so they have a pulse if they're groaning. So they have a pulse, but they're obviously very unstable. So then we're going to need to call a code. So we're going to call for help. We're going to come in. So when people are unstable because of a heart rhythm, we go for electricity. We're going to need to shock this person, but they have a pulse, so we don't want to shock them on their T wave. So we synchronize and shock, and that is called cardioversion. So treatment, if the patient is unstable, equals cardioversion. What if you came in and they were stable and you're doing vagal maneuvers, and then while you're doing that, they start acting weird and getting all confused, and then they faint? Well, then you cardiovert them. You call for help, and then they're going to cardiovert them. Or what if you're, so if anytime they become unstable, we go for the cardioversion. All right, stable, 2 steps. Vagal maneuvers, adenosine. Unstable, cardioversion. All right, we're making our way through. We got 2 left, and they're almost the same rhythm. The next one we got to talk about is atrial fibrillation. In atrial fibrillation, kind of all hell is broken loose up in the atria. So in atrial fib, you have so many ectopic foci in the atria. So you got them all over the place up here. So many. It's really unstable. They're all firing. They're all firing. It's like an electric storm in the atria. And it's all funneling down to the AV node. And the AV node's trying to hold them, and it lets one through, and then it lets another through, and it holds some, and then it releases some, holds another one, release, 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 hold, release. It's just being bombarded. The ones that come through to the bundle branch do travel the normal bundle branch system. So the QRSs are thin, less than 0.12, and normal looking, like a sinus beat. But the P wave situation is a hot mess. In fact, it's just a scribbly line is all you get. You can't even really make out any P waves. It's just a scribble. The way you're going to recognize atrial fib is the spacing of the QRSs is random. It's irregularly irregular. And the reason that we say that weird thing is because later when we do heart blocks, it's irregular, but sometimes in a repeating pattern. So there's a pattern to the irregularity of the rhythm, but not AFib. AFib is just irregularly irregular, meaning it's just completely random. If the rate is very fast and everything's scrunched together, it might look like some of them are spaced the same distance apart because it's all close. But that's just chance. It's not on purpose ever. And what I do is if I'm not sure if it's AFib, especially if it's fast, and I feel like maybe things are spaced the same distance, is I get a really long strip. And then I can be like, oh, here's some gaps. It's definitely just random. So the second thing you're going to be able to recognize a strip as being atrial fib is the scribbly baseline. So it's just going to be like scribbles, QRS, scribbles, QRS, scribbles, couple of these in a row, QRS, QRS, scribbles, scribbles, QRS, and QRSs are all the same. I just can't draw them all the same. So when you first look at the strip, you're going to look at the spacing with your eyes and see that they're really all different distances apart from each other. Then when you try to see if there's P waves, you really have nothing but a wavy line. And then you know it's atrial fib. You can't measure a PR interval. You can measure the width of the QRS, and it should be less than 0.12, and they should all be the same. You really can't measure a QT. It's going to be hard because it's really messed up by the fibrillation waves, is what we call this wavy line, or fibrillation waves. So you can't really get a good QT either. So really all you can do is measure the width of the QRS and get the heart rate, which is, which varies from strip to strip, but you can kind of get a mean of what their average heart rate is. How do they feel when they have atrial fib? Well, they've lost their atrial kick. So, and for you and I, if we lost 15-20% of our cardiac output, we'd probably be okay because we have good cardiac output. But these patients tend to be already sick to start with. A lot of them are COPDers who are already pretty hypoxic. And so when they lose another 15 to 20% of their cardiac output, they can have a lot of symptoms from it. You can have atrial fib with a rapid ventricular response. So we're going to call that AFib with an RVR. That sounds fancy. What's a rapid ventricular response? It means your pulse rate is high. Your heart rate is high. If you have AFib with a high heart rate, you're usually a lot more symptomatic. If you have AFib and your heart rate is in the 70s or 80s, you might feel okay. If you have AFib and your heart rate is in the 130s, you probably don't feel very good. If you have AFib and your heart rate is low, in the 50s, you probably feel terrible. But that's not as common. Why? Because it's an electrical storm up here with a ton of electricity bombarding the AV node. So it's unusual to have low heart rates in AFib. It's more usual to have high heart rates in AFib, and people sometimes do have sinusy heart rates in AFib, but it is common to have high heart rates in AFib. AFib with a rapid ventricular response. And then those people can be very symptomatic. All right, so what are we going to do for treatment? Well, there's a couple of problems. One problem is what's happening contraction-wise up here. With all this craziness, you're getting micro contractions happening all over the atria, completely unsynchronized. And what can start to happen is a lot of micro sloshing of blood, and clots can start to form, right? And I know you guys know about this. So first of all, we got to make sure that no clots form that then make it down through the valves and get out into circulation, either to your lungs and then you get a PE, or into general circulation. And the worst would be like if it went up to your brain and then you had a stroke. But we also don't want a PE or any other kind of clots traveling anywhere. We don't want any clots. We hate clots. So for treatment, one of the first things that has to happen is what? We got to get some blood thinners on this person. So one of the first things is we got to anti-clot, something that works immediately. So right away, we're probably going to put this person on a heparin drip. If it's brand new and they just went into AFib for the very first time, they're going to go on a heparin drip, and we'll have like a protocol sheet, and it'll be based off their weight. They'll get a bolus and then go on a drip. So just get them started right away. We'll start drawing serial PTTs and get that like adjusted so we got them right at the right level, right? Then the next thing is, if they're in a rapid ventricular rate, we got to control the heart rate, because that is going to control their symptoms. Control the heart rate. So if it's high, we got to bring it down. We have some different drugs that we can use to control heart rate. So those types of drugs would be like calcium channel blockers. A really good one would be cardizem. So this is not an anti-dysrhythmic drug. This is just a heart rate reducing drug, right? So first of all, we're just working on symptom control. We're just doing damage control right here. Clot prevention and get the heart rate down. So let's just stabilize the patient first. Now, if we do these two things, step 1 and step 2, your patient is now stable. Everything's fine. We don't have to be in emergency mode anymore. Everything is under control. Sometimes when you bring the heart rate down, so you calm everybody down, just calm them down. As you bring them down, what do you think could possibly happen? This is a chance for the sinus node to reassert his or her dominance over the group of rabble-rousers. And they might even flip back into sinus rhythm at that time when you bring the heart rate down, right? So sometimes they convert when you put them on cardizem. That makes sense, right? Because we know that it's under there. It just needs a chance to become faster than these ectopic freeloaders that are up here trying to take over the heart rhythm. All right, so sometimes that'll do it. Step 3, if the person is still in atrial fib, then we try to convert them back into sinus rhythm. And we have a couple options. We could either do it with medications, anti-dysrhythmic medications, or we could take them for a cardioversion. And now it doesn't have to be like a code blue where we it's a big emergency. Like we could get a consent, we can pre-medicate them, we could do it at the bedside, or we could take them down to interventional radiology or cath lab or wherever we do that in your facility. And it could be like a nice planned procedure. So if we do it with a med, an anti-dysrhythmic would be like amiodarone. That is a rhythm-changing drug. Or we could do a nice planned cardioversion. Either of these are an option for trying to flip someone out of atrial fib and back into sinus rhythm. And I'll tell you how it's going to go. The first time they go into AFib, we can get them out. Later, they're going to come back in. Because what happened is they have some other chronic disease. It's probably lung disease. It's probably COPD. I just know. I'm not psychic, but I already know. And that is what has stretched out their atria. We don't have a cure for COPD. All we try to do is control symptoms and slow the progression, right? So since we cannot cure the underlying problem, later they're going to come back in and they're going to be in atrial fib again. This time we're going to put them on heparin, but we're going to have them leave on Coumadin, because they're probably going to just go into atrial fib again. And maybe we can get them back in sinus rhythm this time, but maybe we can't. And like by the third time, they're probably just going to be chronic AFibbers after that. And they'll just be on Coumadin from that point out, or one of the newer drugs. They're just going to be on oral anticoagulant from that point out and be a chronic AFibber. And they're probably a chronic COPDer. And that's just how it is. So in the beginning, we can convert them, and then later, their underlying disease process usually makes them eventually become chronic atrial fibbers. There are other reasons people are in AFib, but that is the most the most common reason, is because of stretch, and that's from other problems. All right, we're closing in on the end. Last one. A flutter. All right, last atrial dysrhythmia, atrial flutter. So in A flutter, it's very similar. It's almost the same thing as AFib. They're kind of two sides of the same coin. Atrial flutter, you also have a bunch of ectopic foci in the atria. They're all firing, but they get into a weird pattern where they get synchronized with each other. And so they're still firing very fast. In fact, they like to fire at a rate of 250 to 300 times per minute. And because they're firing together in this synchronized pattern, they do actually produce a wave that has like a morphology to it, and we call it a flutter wave. And that's what you're going to see on the strip. When we see those flutter waves, you're like, oh, they're an atrial flutter. It will all still funnel to the AV node, and from there follow the normal bundle branch system. So the QRSs will still be skinny and normal, unless they have some bundle branch problem also, which some people like to have multiple layers of problems to make it very hard to read their EKG strip. So flutter waves are going to be like this, and then you're going to have the normal skinny QRS, maybe a little wide, but flutter waves, normal skinny QRS, flutter waves, normal skinny QRS. So when you see the flutter waves, you know it's atrial flutter. Couple things about flutter waves. Okay, so they're definitely atrial ectopy, so they have all the same problems. Stretch, hypoxia, electrolytes out of whack, so you check all these things. It's very much the same as AFib, so it's almost always the same people. A lot of times people start with atrial flutter, and then it starts looking less and less organized and kind of makes its way over to atrial fib. So some classes, like if you take a dysrhythmia certification class, they'll even have one in the middle that you learn called fib flutter. And some classes are like, there's no such thing as fib flutter. But there really kind of is. Like there's a middle one where it starts looking really hinky and like unevenly spaced, and you can't tell if it's fib or flutter. It doesn't matter. They all have the same problem. But when you see these, they call it sawtooth waves, because like if it was a hand saw, and these are the sharp teeth on it. But some people's flutter waves are more round and decorative and scalloped looking. Like some people will have them like this, but to me it's like the saw teeth are just more facing down. So they can be slightly different. And then they'll have the QRSs like this. One of the things that we write on the EKG for flutter is what the ratio is, how many flutter waves you get for every QRS, like a 4-to-1, a 3-to-1, a 5-to-1, and it tends to be odd ratios. Instead of a 4-to-1, you're most likely to have like a 3-to-1 or a 5-to-1. But here's the important thing to know about flutter waves. They don't stop for the QRS to occur. So like if you measure the distance between flutter waves, you can go point to point. It doesn't matter if you measure under or over. Either way is fine. When you get to a QRS, like the point would be there, and then it would come out there, and it'll be right on time. It just keeps going through. It doesn't pause. The reason that even matters is when you get flutter waves that are just like a 2-to-1 or something, it's really hard. It can be hard to tell it from sinus rhythm, because people have pointy waves. So when you get one that's like just a 1-2 QRS, 1-2 QRS, 1-2 QRS, and you're like, well, maybe that's just their P and that's their T or something, or maybe they're flutter waves. But even if people have pointy waves, a pointy P and a QRS, and a pointy T and a pointy P and a QRS, and a pointy T, see, there's a lot of similarity. But P's and T's, there's a space in between for the QRS to occur. And the T should be a little bit larger, and they shouldn't march out. So like the distance between these two shouldn't be exactly equidistant to this one. But flutter waves will be equidistant. If you put your calipers here, the next point would be there. The next point comes out right on time. Exactly there, exactly there, exactly there, exactly there. We say they march without stopping for QRSs, and that wouldn't usually happen on a sinus strip. So if you're an EKG nerd like I am, then you know you do stuff like that. So those are flutter waves. The treatments are exactly the same as for AFib. They will also get clots. They're less likely to have super high heart rates. So it all depends on what the ratio is. Somebody with a 2-to-1 has a higher ventricular heart rate. We don't care about the atrial rate very much at all. We care about the ventricular heart rate, which is how many QRSs they have. They're less likely to have a rapid ventricular response. If they do, they might need a drug to slow their heart rate down. But what they definitely need is the heparin, so they don't get clots. And then we will try to convert them with a drug like amiodarone, because they're probably pretty stable. If they're not stable, if you go in and they're confused, they have low blood pressure, they've lost consciousness, they're having chest pain, cardioversion, right? When people are unstable and they're in ectopic rhythms, we call for help and we go to electricity. Oh my goodness, that's a lot of atrial ectopy in one sitting. You probably took like 3 breaks, got a snack, you already had like 2 different Cokes or something. You probably don't even drink Cokes. I'm probably the only person who drinks Cokes. But anyway, I hope that you got that and you got it on video so you can go back and look at it again. And coming up next is going to be junctional rhythms. All right. See you soon.